Okay, why don't we go ahead and get started here. Welcome everyone on behalf of the Bold Public Health Center of Excellence on Dementia Caregiving. Uh, my name is Joe Gogler. I direct the Bold Public Health Center of Excellence on Dementia Caregiving here at the University of Minnesota. And just really thrilled to welcome you to what I think is going to be a very exciting and informative webinar today on public health and faith. You see some of my other titles there. My work focuses broadly on innovation in dementia care, and just thrilled to hear from various leaders from different faith communities about innovation that's occurring in this space of helping people living with dementia, their families and communities. It's such a valued, treasured resource, and I know our center is thrilled to be able to be sponsoring this exciting event for you here today. Next slide, please, Alma. I'd like to begin with the land acknowledgement. University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values, courage, wisdom, respect, and generosity. And I just want to emphasize that these are more than words. Not only for our center, but certainly for our presentation today, where I really do believe these important Dakota values are going to be very evident amongst all of our panelists today. Next slide, please. Really briefly, the Bold Public Health Center of Excellence on Dementia Caregiving, PICO for short, is funded by the Centers for Disease Control and Prevention vis-a-vis congressional appropriation. Its goal, in a nutshell, is really to elevate care for people living with dementia as a public health priority. And we do that primarily by supporting state, local, and tribal offices of public health, as well as other organizations in the development of their own support programs for caregivers of people living with dementia, as well as providing information, tools, resources, coordination, and networking opportunities, such as the event here today. We try to improve and enhance access to evidence-based programs and practices to support those who care for individuals living with dementia. We try to facilitate connections and collaboration, both amongst public health agencies, but then beyond as well. And then finally, our center is positioned to provide technical assistance to organizations, whether they be public health agencies or others, to help support their work in assisting and working with and partnering with those who care for individuals living with dementia. Next slide, please, Alma. Before I turn this over to Dr. Lauren Parker, I want to emphasize to everybody, we are very excited to be hosting a national conference next week called the Public Health Opportunities and Challenges of Dementia Caregiving. This event actually is a pre-conference event to our conference to be held next week here at the University of Minnesota in Minneapolis. We also are offering a hybrid option as well. We would love to have you here. It's going to be what we think is going to be a really well-attended conference. And to register, we have the link here for you. You can also go to our website of our center, bolddementiacaregiving.org, to also find more information as well as the agenda. And again, these slides will be shared with you after the webinar today. Again, I really encourage you to consider joining us for what's going to be a very exciting event. So, and actually I see virtual registration only as of today. So I guess you can't come in person. Although to be honest, if you did decide to travel here, we would love to have you regardless. But other than that, we will also have an online virtual attendance option, as you can see. Also, without further ado, I'm going to turn it over to Dr. Lauren Parker. Dr. Lauren Parker is part of the leadership core of the Bold Public Health Center of Excellence on Dementia Caregiving, and in particular is heavily involved in directing our Health Equity Task Force. So Dr. Parker, I will turn it over to you.
Thank you so much for that, Dr. Gargler. And I just want to echo those sentiments. We welcome you. We're so happy to have you taking part of our webinar today. So I have the distinct honor and pleasure of introducing some of the speakers that you'll be hearing from. I'll start off from the left, and this is Reverend Dr. Cynthia Hummel. Just a little bio about her. Dr. Hummel started noticing memory problems in 2003 when she was just 49 years old. It took 8 years until she received the diagnosis of amnesia mild cognitive impairment due to Alzheimer's disease, which runs in her family. She left her full-time ministry and devoted herself to advocating for those living with dementia. The next picture you'll see is the very Reverend Dr. Tracy Lynn. The very Reverend Tracy Lynn is a newly retired Episcopal priest and city planner whose ministry has included work for social and environmental justice, interfaith relations, sustainable urban community, arts and culture, and progressive theology. Most recently, Tracy's ministry has extended to include the spiritual insights and lessons she has gained from a life complicated by dementia. For 17 years, Tracy served as Dean of Trinity Episcopal Cathedral, a thriving and diverse urban congregation, a center for arts and music, and a gathering place for those devoted to Cleveland and its future. The next picture you'll see is that of Rabbi Israel. He is currently a hospice chaplain with Accent Care Hospice of Massachusetts, providing spiritual support to those who are approaching the end of life. Prior to moving back to Boston, he was the rabbi and director of spiritual care for 8 years at Miami Jewish Health, one of the largest nursing homes and senior residential facilities in Florida. As a central element to his rabbinate, Rabbi Israel has become an advocate for dementia awareness. The next picture you see is Dr. Faron Epps. Dr. Epps is a principal investigator of the Faith Village Research Lab and an assistant professor at Emory University, Neil Hodgson's Woodruff School of Nursing. She has devoted her career as a nurse leader to reducing health disparities for underserved population through innovative, culturally relevant programs for the African American community. Dr. Epps is also the founder of Alter, the only nurse-led dementia-friendly initiative to support African American congregation. The next picture you see is that of Dr. Danetta Sloan. Dr. Danetta Sloan is a social work scientist who has a passion for improving healthcare equity for aging Black Americans. She believes that it is her ministry to seek ways to improve healthcare delivery and access for Black Americans through faith-centered initiatives. Dr. Sloan is currently an assistant scientist in the Department of Health, Behavior, and Society at the Bloomberg School of Public Health. Her work uses participatory methodologies to partner with Black churches and faith communities to strengthen community capacity in early diagnosis and access to care, and future care planning for those who experience dementia. And last but certainly not least is the last picture you see is that of Jenny Beggars. She is the executive director for communities Us Against Alzheimer's, and has been with the organization for 10 years. In that time, she has built multiple advocacy coalitions, including the Faith United Against Alzheimer's Coalition. She is now program director for the Us Against Alzheimer's A-List research and the What Matters Most Insight study. As you can see, we have a wealth of knowledge and expertise on this call, so I'm so delighted to get us started with the conversation today. Before we start to hear from the speakers, we'll have a short introduction message and prayer from Reverend Dr. Cynthia Hummel. I'm not sure that we can hear it, so we'll start it over from the beginning just so we can make sure that the volume is all the way up so that we can hear the message.
For joining our Public Health and Faith webinar today. I'm the Reverend Dr. Cynthia Hummel from Owego, New York. I'm a retired Presbyterian pastor, and I recently celebrated the 25th anniversary of my ordination. I'm also a person living with early stage Alzheimer's disease. Creating partnerships between public health and faith communities is not a new concept. I know that there's a strong history of public health programs being held in faith communities like the ones I've served over the years, where individuals and families are able to get important wellness and mental health services right in their neighborhoods without having to travel so far. Let me share just a few programs that were hosted in the Lions Presbyterian Church, where I served as the pastor for 11 years. The church hosted programs like WIC, Women, Infants, and Children. They held prenatal and early childhood screenings and clinics, and they provided educational events for new parents. We hosted Alcoholics Anonymous and Narcotics Anonymous groups, along with depression support groups. We were a satellite office for domestic violence programs. We held blood drives. The church has a thrift store and a food pantry for those neighbors in need. These partnerships are not new, but what might be new to some people today are programs and services for those who are living with dementia and for our care partners. Today, you're going to hear about some of these programs: art programs, support groups, screenings for dementia, and the benefits of working together to create strong partnerships between faith communities and public health. I am so glad that you've joined us today to get ideas and to share ideas about programs that are working in your neck of the woods. Imagine if each one of us attending today's workshop could partner with a faith community, with a public health agency, to create one new program, one resource for someone living with dementia, for their care partners. Think of the possibilities, think of the potential in helping to create and offer programs and resources, and the difference that those programs could make. I'll be in prayer for you today, and I'd like to offer a prayer as we begin our day together. Let's pray. Dear Lord, we thank you for the opportunity to gather here today. We've come to listen and to learn from one another and to share ideas and programs so that we might all better support and resource those in our communities who are living with dementia, as well as support and resource our families and our friends as well. We're all in this together, Lord. So please bless and strengthen these connections. Yes, be with us, Lord, as we explore, create, and build partnerships between public health programs and faith communities. Help us to look for ways to share the care. We come from very different communities, big cities, rural settings, the suburbs, tribal territories, and beyond. And we come seeking your blessing for our shared vision of better caring for your people who are dealing with a dementia diagnosis. Let them feel your love and ours. Lord, we're a diverse group. Some of us work in public health, others in and for various organizations and industries. Some of us work in academia. Some here are working in faith communities. Some of us are care partners, and some of us are living with dementia. We have our differences, but we share a common bond, caring hearts, and a legacy of love for your people. We are so blessed to be able to meet together, Lord, and we ask your blessings on our day as we seek new ways and new opportunities to partner together. We love you, Lord. Amen.
We are so appreciative of that prayer, and I hope that that kind of sets a good tone for the conversation that we have today. So to get the conversation started, we'll have Dr. Fayron Epps and also Dr. Donetta Sloan come on and think of this conversation that we're going to have as just a conversation. I actually have the pleasure of knowing these two dynamic scholars personally. So just imagine we're all sitting around having a conversation. And if you have any questions as the conversation is getting going, please feel free to type in the chat, and then we'll get to the questions afterwards. So I just want to say welcome to you two, Dr. Epps and Dr. Sloan. Just to kind of get us started, started, can you please share why it's important for public health agencies to see the value and role of faith communities?
Thank you very much. I didn't know, are you talking to me or Dr. Epps? I don't know which one you want to start.
Conversation.
Okay. Thank you so much, Dr. Parker, for introducing us. Introducing me. You did a wonderful job. I feel that it's really important for public health and public health agencies to be involved because, outside of the medical risk factors, there are other risk factors and protective factors as well that impact dementia and impact the social determinants of health, right? And so it becomes all of our responsibilities to be able to address some of these challenges. Our healthcare providers cannot do it alone. It's just not, the workforce just isn't large enough. So we need our public health organizations and agencies to partner and engage with the communities to try and provide support for our caregivers to help improve the quality of life of our caregivers and all people who experience dementia.
And I would add to piggyback on Dr. Sloan, when we look at faith communities, they tend to be the cornerstone
Yes.
of a lot of communities, right? Not just in the Black community. And I just think it's so great for us to acknowledge that they're the cornerstone. And this is the place that many families will go to, not to get their spirit fed, right? But they also go here for resources and for support. And I think it's very important for us and public health agencies to understand that, the church is an arm of the public health agency, and they need to be informed. And one of the things, Lauren, a lot of people, we may assume, me working in this field, we often assume that the pastors know it all.
Mm.
But they don't, and they need us just as much as we need them to be able to serve the community, to improve health outcomes. And I think we really need to recognize that. And again, they don't know it all.
Mm-hmm.
And we need to be there to make sure that we share with them the information, the statistics, how things are being hit, how hard things are hitting their community, so they can fully understand. And a lot of times dementia and caregiving hasn't been at the forefront. When a lot of other conditions, I have to say diabetes, a lot of churches have programs to help with diabetes, to lower blood pressure, those things. But really, again, dementia, caregiving, talking about care partners, that has not been at the forefront on the agenda for many faith communities.
Right. I really appreciate how you said that churches are an arm of an extension and thinking about community and as an aspect of resources. Dr. Sloan, did you want to add something else?
Yeah, the other thing is churches provide natural networks, right? Natural networks to the broader community. And Dr. Epps was saying that it's so much that they don't know. And in my experience, resources may be around them, but they have no idea. And also when we think of, cognitive challenges, there's a lot of stigma there within our communities. And so you have many families who are experiencing dementia, but they don't want to say anything. They don't know who to reach out to. But they will reach out to the church. The church is trusted. And so they will reach out. And it's really important to have people within the church that may know about dementia. So it's up to us to partner with the churches to help provide that support.
That's a great segue. So I know that you both are in different locations. I was just curious because you all are both in academic settings. Can you really briefly share the great work that you're doing in your individual faith communities?
Sure. Okay. Um, I actually am in Baltimore, Maryland, and I partner with churches in Baltimore, Maryland, a rural area in Pennsylvania, and Southern Virginia. And my focus is really on embedding information into the church so that when the community reaches out to the church, someone will be there with knowledge. So I go in and I partner with the leaders in the church, the health ministry or nurses ministry, and I provide training on the signs and the symptoms of dementia, also what the caregivers should be concerned with at each stage of dementia. And I focus heavily on future care planning because there is so much unknown about what to expect as my loved one goes through or negotiates the symptoms of dementia. And by providing that training to the volunteers within the ministries, I then require them to facilitate a workshop to the larger congregation to provide information to the larger congregation. And, so far it has gone overwhelmingly well. I think the only challenges that I've experienced is that people will register and then they will bring their friends, their neighbors, their spouses. So then it kind of grows. And but the feedback that I've received is needed. This information is needed in the communities, and it's important that we go to the community, and we go and we provide ways that the information or the intervention that we're doing, and I don't like to say intervention. I like to strengthening the capacity in the community that they already have, right? Is that they're able to sustain it. And this is one of the ways that I see that it can be sustained. And so the church that I have worked with, they have named their program Affected African American Faith Communities Transcending Dementia. And so I'm really excited to engage with them as we move through our stages.
I love the transition. I love that.
Yeah, I love that. And so I believe Dr. Sloan and I, we work in similar areas. And as I am based out of Atlanta at Emory University, I have a program called Alter Dementia that I'll put in the chat box. But this is also similar to Dr. Sloan's. It's a partnership with churches, but we can partner with churches across the country. And we predominantly partner with African-American churches to give them the tools that they need. And so we go one step beyond education. And again, we provide them a framework that not only are they going to be providing education to their congregation, but also supportive services. And also we address worship with the leaders. What are those modifications? And all of this is around supporting families and parishioners that are on their dementia journey. So either if they're living fully with dementia, living with dementia, or a family caregiver or a care partner, we want to make sure that they have the tools and the resources. So almost like when Dr. Sloan said, when someone comes to the church for support, that they know exactly what to say, but also who to call and what resources to connect them to. And then for them to also implement programs within their congregation or partner with other churches. And our ultimate goal is to have a whole network, a dementia-friendly faith village network, we can say, but a network of Black churches that, that they can learn to work with each other, be able to get advice from each other, and then no matter where anyone is in the country, they can go to our website, look at our map, and if they need to find a dementia-friendly church that has been through our training, they will be able to do that. And so we are in Illinois. I'm paying attention to the chat because Journey to the Cross is one of our partners, just showing how we're trying to expand outside of Georgia, because we really want to make sure that there is a strong network for families to be able to lean on their faith community. So a lot of things, I do research in this area, and that's what started is a lot of families had church hurt, right?
Yes.
And they had the church hurt because they would go to church, but no one understood what they were going through, even if they were a family caregiver, they were living with dementia. And so they're like, oh, okay, and they feel abandoned. And then they stop going to church. And I think I am dealing a lot with that. I'm trying to mend that church hurt and making sure that pastors understand that this has occurred because of dementia, and how that lack of knowledge within the congregation and not knowing how to support their parishioners and their families that are facing this. And also now letting families know that churches now see that this is a priority. They're adding this to the agenda. They trying to learn about it so we can bring these individuals back to the church, because a lot of older individuals, the church was it was prominent for them, as they were growing up. And it's meaningful to engage in all activities and then be able to go to a support group at their church, to be able to have a respite program at their church. I mean, it's really, really beneficial for the families.
What I appreciate about both of you all is that you all both are researchers and scientists, and it's that you all are creating solutions to problems that you all are identifying in your own community. So that's so exciting to see. And so I just want to applaud you. I know I'm always cheering you on from the background, but I want to cheer you on in front of everyone too. But that is just so admirable. I'm just curious, since you all are scientists, you are all in academic settings, and you develop supports for dementia supports for faith communities, how best can public health agencies or other people reach out to support the work that you're doing? I appreciate you putting the link to the Alter program in the chat, but how are other ways that public health agencies can reach out to support the work that you're doing?
The work that we are specifically doing, I think just, of course, we can put our contact information. I'm gonna speak for Dr. Sloan too. We'll put our contact information. But, not only just contacting us directly, I also say if you have a church in the areas that we serve that you're interested in supporting, and you want to bring more resources to them, contact us. So sometimes, we have agencies that I would say I have agencies that contact me directly and say, we want to partner with you and offer more resources to your church partners. That's good. But then we also have agencies that say, hey, we're working with a church and they want a little bit more than what we can offer. Can you partner with us and provide them more information? But the main thing is just contacting, let's have this conversation. Again, I am trying to make sure that, I am able to reach churches in each state, each area across the country, so we can have these resources specifically for our Black families, since they're disproportionately impacted by dementia.
Yeah, I appreciate that, because it's the rate is African Americans are twice as likely to develop dementia compared to other groups. So it sounds like, again, creating solutions. Dr. Sloan, did you want to add to that?
No, I agree with Dr. Epps. I experienced the same thing. And what I can say is that in engaging with my churches, they need resources. They need support. I go in and I connect them with resources, but often what I find is that they are having difficulty with obtaining those resources themselves. Oftentimes they don't know how to navigate the system. And, we do have other agencies that provide excellent resource information. electronically, but many of our older people aren't able to go in and click this link and click that link, and then it's just very confusing for them. So that is one of the ways that I have seen that I have been able to be helpful, but it would really be helpful if public health agencies can reach out to the churches and engage with them, and to the communities, because these are communities of churches. So it's just not one. I can do a workshop and people are there from other churches that come up to me and say, hey, can you come to my church and do this? Because we know nothing. And so, and what I find is that there is a lack of just knowledge, maybe, around what is available and what resources are there. Although the agencies may be in the state, there's not a connection. We need a bridge to be able to help our communities.
One thing, go ahead.
No, I was going to say one thing where you say that they need the resources. Since we have this audience with public health agencies, I think it's very important that we really stress the importance with our team, with our staff, that we do need to go to the church.
Right.
We do need to go to
Yes.
those areas. And so, I'm gonna be honest with you all, I get upset sometimes. So, because when I am partnering with other agencies and public health agencies, and I start asking them because they want to offer this help and they say, we have all these resources. Well, I say, well, have you been here? Have you knocked on the door? Have you called? And the answer is no. And, then that kind of upsets me, because how can we really get all these great resources and these help to these communities that are really in need of it, these underserved communities, under-resourced communities, if we do not go to them? So it's very important that we do go to them. And when events come up, and if they open their doors and they invite you, please make all the effort that you can to try to attend or send a representative, because that just means so much to them. But I'm faced with that a lot, and it's just me that's showing up, and it's not my other partners that people I'm trying to partner with, right? That wants to come. And so, I think, we trying to make the case right here today that partnering with faith communities are very important. They're an extension of the public health. And we need to make sure that we have them at the table and that we do go to them and bring the resources.
And I think just to piggyback on that a little bit, what I would like to say is that, and when we go build a relationship. Sometimes what happens is a representative from the agency may go and present and say, and this is where you can find us, and then they never go back again. Build a relationship. Some of the leaders, especially now since we have gone virtual, many churches are in person, but they have a virtual arm as well. The leadership is changing, or the volunteers change, they move around. So it's important to have a relationship with the church so that when those changes take place, you can still maybe engage in a trusting relationship with the new leaders or the new volunteers, but it is important to build a relationship. What I have found, and I had a representative from a public health agency to say, how are you connecting with these churches? I've been there. Yes, the key was I have been there, but you presented and you left. Did you go back? Did you build a relationship? Or, can I recruit there? Well, have you built the relationship? It is important that our agencies build relationships within our communities.
Right. I so appreciate you speaking on the role of relationship and also trust. It seems that trust is very important to these types of relationships that you're having, because, leaders and these faith communities are really trusting you to go in front of their congregations or whatever practitioners that they have to provide this information. So can you please share how is trust developed between yourself and faith communities?
You know, did you want to go first? No. I chuckle a little bit because, oftentimes people automatically feel that, and all the churches that I've worked with have been African American churches thus far. And people automatically feel that since I am African American, I am automatically trusted. That is not necessarily true. I work for a large academic institution that is well known. And so when I come representing that institution. So I have to build a relationship like most people. And what that takes is, it's not 9 to 5 at all. It is showing up to be present at events that they may have, showing up on the weekends, or if they ask me if I will come and speak, I do that because it's part of the building a trusting relationship, and and constantly being in contact. Dr. F.
I think you hit the nail on the head. And I think one of the things to stress is, especially with agencies, with those that are listening, that it is not 9 to 5, because many pastors work a 9 to 5 job. So let's just be honest here, especially in the times that we are in. And so a lot of times that their meetings have to be in the evening, and may have to be on the weekend. And so we have to understand that we as scientists, we as healthcare professionals, that we need to be flexible within ourselves so we can be available for them. And we can build that trust. And I think that's one of the successes that I feel like I work all the time, but it's all good. But I am available in the evening and on the weekends, because I understand that they do have a Monday through Friday, majority of them. And to get that information to them. And I want to say that they really appreciate that. When they see that I'm able to give 7 o'clock, give up my time at 7 o'clock or 8 o'clock to have a meeting with them to discuss these issues, they appreciate that I'm willing to come on a Sunday or Saturday. And I see that appreciation. Sometimes they don't say it, but I have had a recent invitation to deliver a sermon. And so it got to the point where, what, Dr. Epps, we're going to give you church service. You're going to deliver the message. And so, that showed me they appreciate it, and they have established that trust with me for me, to allow me to get up there and talk about how important caregiving is, and having supportive services available for their caregivers and their parishioners that are facing dementia. And so again, it's just making yourself available. And as we close, I want to make sure that we need to be responsive to the needs of the faith community as well. So, I know we talked about bringing our resources in and stuff like that, but we need to make sure we're bringing in the resources that they need. So, and that's what I mean by being responsive. So being responsive to the faith communities that you're working with, finding out what they actually do need, and you bringing in those resources to help them.
I so appreciate that, because I think we could talk about this all day. I know I could listen to you all and have a conversation, but to be mindful of our time, I was going to ask this, my last question: how do you identify the resources that your community needs, that the faith community needs? I know that we have an agenda sometimes as scientists to go in it and provide assistance. But how do you identify and work with communities to provide their needs?
So we always have initial meetings, because, many times, we can just, people have probably heard this before, right? When they think that you work in the Black community and the African American community, all the needs are the same. And that's not the case. When you work in churches, all the needs are the same. And that's not the case. And so when you work in the African American church, all the needs are not the same. And so it really takes that time where you need to have that initial meeting. And I'm going to say initial meetings with an S, because sometimes everything is not accomplished in one meeting for you to really understand what their need is. And so, we have multiple initial meetings, and we also provide them a pre-assessment for them to tell us about themselves. And then we're able to discuss those things in our meetings and learn more about their congregation and understand how this is different from maybe the last church that we work with. And we come together to devise the plan that they would need. So for those nurses that are on a call and other healthcare professionals, just know, like, we're doing individualized care plans. And that's how I approach it when I work with the churches.
Thank you for that.
And I really follow the same pattern, the same method. But when I go in, I'm really aware of what it is I would like to do. However, it's just really important that I meet with stakeholders. I have a community advisory board, and I find out about the community and the needs of the community before I really go into detail about my research, because I feel that is the most important thing to do. First, as a social worker, I realized that if people have immediate needs, they cannot engage in whatever it is you may be asking or whatever you may want, because their needs have not been addressed. So it's just important to find out what those needs are of the community.
Well, thank you so much, Dr. Sloan and Dr. Epps, for your time today. And I know that we have a question and answer period, so please keep your questions coming. At this time, I'm going to turn the moderating microphone over to Jenny so she can have our next conversation. So thank you so much.
Great, thank you, Dr. Parker. Next, we're going to talk in more depth about why faith communities are powerful sources of support for people living with dementia and their families, and valuable partners in public health. I'm joined by two fantastic people who will share their firsthand experiences. The very Reverend Tracy Lind, who, as you heard, is a retired Episcopal priest for 17 years, serving as Dean of Trinity Episcopal Cathedral in Cleveland, Ohio. She retired from that position after being diagnosed with frontotemporal dementia in 2016. And her ministry now focuses on sharing spiritual lessons gained from her experience living with FTD. And Rabbi Israel de la Piedra, who is hospice chaplain with Accent Care Hospice of Massachusetts, providing spiritual support to those approaching the end of life. Previously, he was director of spiritual care at Miami Jewish Health in Florida. So we will be addressing these key questions. We'll talk about a little bit of research that Us Against Alzheimer's has done, and hear perspectives of person living with dementia and faith leaders, and try to talk a little bit about best practices, some building on what we just heard, and have an initial kind of conversation about some programs that work well. And next slide, please, Alma. So in one of my roles at Us Against Alzheimer's is leading our A-list research in the What Matters Most Insights study. 3 years ago, we surveyed people living with dementia and family caregivers about the role of faith in their lives. 70% of respondents said faith sustains them on their journey with dementia, and that's both people living with dementia and caregivers. And 72% said they want support from their faith communities, but resources are often not available. And I think that this just points to the need. I think it's clear, but I think to have this data that clearly shows this is, as we just heard, a place where people go. It's important spiritually, it's important for resources. I'll also add that more recent research over the course of the pandemic that we did over about 13 months, 81% of caregivers said they felt more isolated than pre-pandemic, and 57% of caregivers felt lonelier than before the pandemic. So the need, I think, has only grown that we're talking about here today. And with that, Elma, I think we can go to we'll go to our first question. So welcome, Reverend Lynn and Rabbi Israel. And you both can, if you haven't, turn cameras on and microphones on. It's wonderful to see you both. Thank you for joining us today. And Reverend Lynn, I'll start with you. Can you talk about why faith and faith communities, from your perspective, are important to people living with dementia?
Thanks, Jenny. I'm really glad to participate in this webinar because I think it's really important for public health professionals to hear firsthand from people like me and Cynthia, individuals living with dementia. And I think it's really important that we honor this commitment to training not only congregations and congregational leaders, but also public health officials and public health workers. And just to frame it a little bit, I do have FTD. I was diagnosed in 2016, but I also am the daughter of someone who lived with Alzheimer's for many years. So I have been a caregiver, I've been a daughter, and as the pastor I've been ordained 35 years. In my congregations, I've seen a lot of dementia, and I've visited on a lot of homes with people struggling with dementia. And I've also been one of those clergy that actually has shown up in memory units and nursing homes and retirement communities. The faith community is aging, and our churches and our synagogues and our mosques are getting older. And according to the Pew Foundation, approximately 1/3 of our congregations are over the age of 65. And the median age of Protestant, Catholic, and Jewish congregants is 50 plus. So given these statistics and the statistics that you all know as well as I, probably better, about dementia in our community, we are likely to see an increase in dementia in the active faith community over the next several years, especially as we boomers age. As we grow older, our faith, including our questions of faith, become more meaningful and more important to our well-being. We start asking the questions perhaps we didn't have time to ask when we were working and raising children and managing households. And our churches and our synagogues and our mosques become more a part of our daily life and our support systems. And you've been hearing about that from the previous speakers. So the majority of older Americans are religiously affiliated still, and we attend worship and participate in congregational programs on a regular basis. And moreover, mainline congregations, especially larger ones, and historic Black churches, have expansive networks in the wider local community. So if you're looking to reach individuals living with dementia and our families, faith communities are a good place to find us. And we clergy are often the ones to recognize dementia among our parishioners. If we're paying attention, we're the ones who see it. And we often, if we're paying attention, are the ones to recognize care partner burnout and exhaustion. And we're sometimes, if we're good pastors and good rabbis and good imams, we're often the ones who are asked by families to help facilitate decisions about resources, about assisted living, and about that really complicated move into memory care. And if we're good and faithful pastors and rabbis and imams, then we are often the ones that need to show up, especially toward the end of this long journey. But here's the caveat, that individuals living with dementia, and I know this as a pastor, and I'm learning it firsthand, we and our spouses and our families become increasingly isolated, and we often disappear from congregational life. Why? Well, it's hard for a couple living with dementia to get together and to get to church by 10 a.m. on Sunday morning. It's hard for a person living with dementia to follow a traditional worship service. It's hard to participate in an adult education class. It's hard to handle the chaos of coffee hour. And as I've learned firsthand over the past few years, as I traveled the globe visiting congregations, it's hard to find your way around a lot of our congregations. So congregations can and should be visible communities of acceptance and belonging and compassion, where we who live with dementia and our families can find homes of welcome and embrace, so that we can express the full experience of dementia with its pain and sorrow. But it means that congregational leaders, clergy and laity alike, have to develop an intentional practice of really seeing and knowing and understanding and appreciating and including we who live with dementia and our spouses, and in some cases our children. And that means coming close to that which many of us fear about growing older, and that's dementia. Clergy are no exception, and lay leaders in churches and synagogues are no exception to being frightened by dementia. Now, here's a few specific ways that I think we can support people living with dementia in our families. Worship and education, fellowship and facilities can be adapted to be more welcoming and accessible. And public health officials can kind of help see some of that. Congregations can encourage and help make our local communities more dementia friendly. I'm working on that in Cleveland Heights right now with our public health community. Clergy can be encouraged and can be trained to be present as dementia progresses. We don't learn that in seminary, and that's something we can benefit from you all teaching us. Lay people can help organizing home help for families living with dementia. I don't mean nursing help, but maybe organize sending over some meals, or sitting with someone who's at home with dementia so their spouse can go out to lunch or get her hair done. Congregations can host support groups for people living with dementia and for our care partners. Congregations can work together to create support programs for people living with dementia, respite programs. I'm not talking about daycare. None of us who are living with dementia, who are younger or in the early stages of this, want to hear the word being sent to daycare. I'm talking about wellness programs where we are encouraged to feel good about ourselves and take care of ourselves. Dementia cafes where we can gather and have conversations. Two fabulous examples around the country are the amazing place in Houston, Texas, which was started by a collaboration of congregations, the amazing place in Houston, and the Founder's Place at St. Luke's Episcopal Church in Birmingham, Alabama. Maybe you all Southerners have a better sense of how to offer hospitality than we Northerners do. And congregations and denominations can become allies in the lobbying role for legislation, research, and funding. And those are just some ways. And lastly, I want to say that clergy in particular, if we can be trained not to be afraid of this, can engage those really deep questions that people living with early stage dementia have. And those questions and that anger and that fear and that confusion that our spouses and families have.
Thank you. And Rabbi Israel, can you talk about the special role that faith-based organizations play in supporting families, individuals who are managing dementia? Is there a comparative advantage, if you will?
Thank you, Jeannie, and thank you for inviting me to be here. And thank you, Reverend Lynn, for going first so that I learn from you as I'm going to try to respond to the question. I think that faith-based organizations have a special role to play in the fight against dementia because they represent what is holy in society. You see, God's blessings comes to God blessings come to us through what we do for each other. God's blessings don't just fall off from the sky, if you will. In that sense, God's blessings for those who are suffering from dementia come through what we all do for them. That's the way the blessings come. So people who work in faith-based organizations and clergy, like myself, we have a special role in this regard. Of course, we all can bring God's blessings to others. But clergy and others who work in faith-based organizations are many times seen by members of society as the embodiment of God's presence in their midst. And so this is the reason that underlies the special role we can play and we should play. It is because people will think of our work as being divinely inspired. We're not better than others. We're not certainly holier than others. It's just our role. We all have one. As we see ourselves as vessels for God's blessings that we pass on to those affected by dementia, I think that the concept of being created in God's image, which the Bible teaches us in the very, very first verses of it, acquires a clear sense. We are created in God's image because it is through us that God's blessings will go and come to others. We act in a holy manner. We act in God's image when we are able to channel God's blessings to those around us, to those affected by dementia specifically. Faith-based organizations are the collective through which these holy blessings take place. Faith-based organizations help bring divine blessings to those with dementia, both through the personal action that all of us who are members of those organizations do in our personal capacity, but also through the role of these organizations in leading community action. So many things like what Reverend Lynn has been teaching us about. I think there is a clear case for faith-based organizations and public health organizations to work together in favor of those affected by dementia and their families. The mission of faith-based organizations is to bring spiritual well-being to those whom they serve. At the same time, dementia is a public health concern. Pairing these two objectives, public health and spiritual well-being, provides a comprehensive framework for the fight against dementia. The growing nature of the problem of dementia in our society calls not only for an enhanced role for each of these two, the public health organizations and the faith-based organizations, but also for enhanced levels of collaboration between these two. We have been hearing this morning from the previous speakers, as well as from Reverend Lind, ways in which this can be done. Public health agencies bring the power of the public purse and the weight of society. And faith-based organizations bring the power of spirituality and their unrivaled ability to reach out to those affected by dementia and their families. And so working together, they will multiply their reach. One, by helping faith-based organizations access public financial support so much that is needed so much for religious and other activities that are especially designed for the benefit of those suffering from dementia and their families. Also by helping public health institutions access knowledge that will allow them to create better programs in favor of these populations. And finally, helping both faith-based organizations and public health institutions work together and create synergies in the fight against dementia that add to more than the sum of parts.
Mm. Thank you, Rabbi Israel. Reverend Lynn, we heard a little bit about this in the first segment, but from your perspective as a person with FTD, as a minister, can you share for public health professionals who want to engage more with faith communities, what's the best approach? What should they keep in mind? Who should they talk to? Can you share some advice on that important connection, making that important connection?
Sure, Jenny. I think what our first two speakers said about showing up is really key, and not expecting the clergy and lay leaders of congregations to necessarily reach out, because quite frankly, the faith community is pretty strained right now in terms of resources and capacity. I would say that many congregations, especially those who are likely to work with a public health organization, and that means the historic Black churches, the mainline Protestant congregations, some of the Roman Catholic churches, some of the more mainstreamed mosques, and the synagogues that are more likely to engage in the wider community, often participate in clergy associations and interfaith organizations. And a good way to reach congregations is through those efforts, because whether we think it's the best or not, it usually is the clergy who are the gatekeepers. We're usually the front people. And so it's really helpful to get to us first. Either get to us through members of our congregation who have this concern, or get to us in the places where we gather, or get to us in an organized one-on-one campaign. In Cleveland, for instance, the Benjamin Rose Institute on Aging has been organizing dementia-friendly Cleveland Heights. And they have met with the clergy associations, and they have offered training for clergy and lay leaders. Greater Cleveland Congregations, which is a large interfaith organization that I helped to found and served as one of the 3 co-chairs, along with a leading African-American Baptist minister and a Reform rabbi. We have been working, or they, I'm now retired, have been working with public health officials and funders on a really effective and creative campaign of getting folks vaccinated for COVID. We've been paying people to get their shots, and it's really been working in a community where there's been a lot of resistance to it. We did the same kind of work when it came to the HIV/AIDS crisis, especially in the 80s, before conversations about AIDS was mainstreamed. And so meeting with clergy associations, getting on the agendas of those interfaith gatherings is a really useful way to do it. Most larger congregations have significant adult educational programs, and trying to get on those agendas is also really helpful. When I had to step down from my position as dean of the cathedral, we enlisted the local Alzheimer's Association to help the congregation understand what I and others were dealing with. And if we had known that we could have reached out to public health organizations, we probably would have, but we didn't know those resources were there. It's really important to remember, though, that many congregational leaders are volunteers and not paid professionals. Most congregations these days have one or two paid clerics and maybe a couple of paid professionals. So it's really helpful to tap into self-interest, helping us understand why we should be doing this work. And finally, I just want to reiterate to not forget to invite people living with dementia to help in this effort, because we have the lived experience. And one of the things that can happen, especially in the early days of mild cognitive impairment and diagnosis, is we don't have anything to do. We're no longer working. And so we actually need opportunities to continue to give and to continue to serve. So I want to always keep reminding us of that we've got the lived experience. And, we approach dementia from a deficit perspective as opposed to an asset perspective. And I'm trying, and some of my friends around the country are trying to say, let's look at the assets that we still bring to this conversation.
And I will add, I think that perspective, your perspective, makes it better. Whatever you're doing is going to make it better and more effective.
It also makes us better. If I keep working at using my brain, I'm going to have it for longer.
Right. So Rabbi Israel, you have worked in long-term care and now hospice. Can you talk about programs you've seen that have really improved quality of life for those living with dementia and importantly, family caregivers?
Thank you. And Reverend Lind, I would say, not only does it make you feel better, but when I mentioned that we act in God's image when we channel blessings to those who have dementia, they also act in God's image, channeling back blessings to us. It's a two-way street, and sometimes it's not clear that we are the ones that give more than we get. Successful programs by faith-based organizations in favor of those living with dementia are based on three major areas, I think, where these organizations are special. First of all, it's obvious, it's prayer and ritual. Prayer and ritual are proven to have a beneficial effect on people's health, even more when they get older, and even more when they are affected by dementia. This is amply documented, but I don't think anybody of us needs to read about it. We know it. We know it when we do it. And it's just so important. And of course, faith-based organizations have a natural advantage in providing religious services to those affected by dementia and their families, whether at the church or the temple, or whether at the places where they live, as Reverend Lind was also calling for. We all can lead with love and compassion prayer services, and we do it. But I think it takes intimate knowledge of religious tradition to be able to design such services and then put them out so that others can increase the effect they have. I would just like to mention, based on my experience leading weekly Shabbat services for people with dementia at Miami Jewish Health for several years, that, for example, what made that service successful, I shouldn't be so modest here, it was very successful. And what made it successful was a few things. One, these services were short, some not more than 15 minutes. They were song-based, which in addition to prayer, song brings out something, especially when song is part of the religious tradition. The services were infused by tradition. What I mean by that is that there's a need to make the rest, or I had the need to make the residents aware that this was a religious service. It was not just another activity. I remember once they wanted to give me instruments so people could make noises as we sang. I said, no, that's for the music therapy later on. This is prayer. And we'll just sing. And people were singing. The services need to be predictable in time and content. People with dementia, the more dementia advances, they need to be familiar with what's happening. And most importantly, I would say, for me, the most important part of the service was before and after the services, when I would go around saying hello to each one of the persons and giving them personal attention. By the way, this service is described in the book that I will show here. I don't know if you can see it. No, it doesn't cover. I'll put it in the chat. It's a book called Dementia-Friendly Worship, and has edited by Linda Everman and Don Wendorf. It has examples of services in all sorts of tradition. I put it in the chat. In addition to ritual and prayer, I think another area where faith-based organizations excel and can help others do so is in making the focus of the work we do with people of dementia, the family, the unit of care, as we say, is the family, not the individual. Public health organizations, by their nature, are focused on the individual. Maybe with the exception of hospice, where I'm working now, it's never the family as such, it's the individual. The unit of care for a church, for a temple, is the family. And that's what we need in order to work with people with dementia and their families. So ritual and prayer and the family as the unit of care. But something else that has been mentioned now and was mentioned earlier, I want to use exact words that Dr. Epps mentioned, faith communities as cornerstones of our communities, and Dr. Slow mentioned them as a natural network place for communities. Faith-based organizations have a moral authority, a degree of moral authority that other institutions don't have at that level. And this moral authority arises from the special place of religious institutions and the representatives in society, which gives them credibility and hopefully impartiality in the eyes of others. And the fact that older people, this has been mentioned again and again, the fact that older people, among whom people with dementia are overrepresented, is a natural constituency for faith-based organizations. And let me cite in closing just an example where I think it's a real example of an area where I think faith-based organizations can actually use their moral authority to press for change. As has been said, I now work in the world of hospice. And a problem we're facing in hospice is that Medicare regulations meant to clamp down on abuse, which of course we need to clamp down on abuse. But the way it's been done, the regulations meant to clamp down on abuse are linked to measures to discourage longer stays than necessary in the system. Stays in hospice are not meant to be long. Unfortunately, it's for people who are close to dying. The longer stays, however, which are used as an indication of possible abuse, these longer stays are not necessarily linked to abuse. Sometimes they may be linked to diagnosis of illnesses that have a longer duration. And it so happens that people with dementia stay in the system, in the hospice system, for about 30% longer times than regular or people without dementia. And so there's a need to lobby Medicare to make sure that as they clamp on abuse, they are not at the same time doing something that affects negatively the population of people in hospice with dementia. So that's just an area where we could, as faith-based organizations, we could make a difference. Thank you.
So we have just a couple of minutes before we turn to the wrap up and to Q&A. Reverend Lynn, could you give just a closing thought that will inspire our audience to go out and engage with the faith organizations in their communities?
Thank you. Again, I just want to reiterate that I think congregations and faith communities are a powerful place to reach people who are dealing with dementia. It's an excellent opportunity for public-private partnerships. Congregations have space and we have people. And as you heard Rabbi Israel said, we have moral authority, and in the best of times, we have people's trust. That's challenged once in a while. We have volunteers, but we need expertise, we need training, and we need funding. And that's what the public health community can bring to the table. But here's the one challenge that I want to raise, is we are coming out of what I call COVID tide. And many clergy are asking themselves, who are they and what are their congregation going to be in the future? The burnout rate among clergy and lay leaders is really high right now, and many congregants have fallen away. So offering something fresh and new that is really on our doorsteps anyway is really good for clergy, and it's good for energizing congregations. And dementia might just be that. So in closing, what I would say is this, that the faith community can come to us when we can no longer remember who we are. They can become our memory. And when we can no longer care for ourselves, they can support our spouses and partners in doing that. And when our spouses and partners get exhausted, they can help offer respite. And when we find ourselves in assisted living and memory units, the faith community, clergy and laity alike, can be voices that push back and help caregivers resist the temptation to infantilize us, but rather see and treat and respect us as mature adults. And finally, the faith community has the power and the moral authority to advocate on behalf of those of us who are living with dementia, so as to encourage a society that provides a quality of compassionate care, that understands and recognizes and respects that there's still an adult person living in the midst of confusion and memory loss. And I think it's fabulous to think about this partnership one that we've done before with HIV/AIDS, one that we're doing with COVID, and now to do this to meet the growing public health crisis of dementia care.
Well, incredibly well said as always. And I want to thank you both for sharing your wisdom. And with that, I will turn the floor back to you, Dr. Parker. So thank you both very much.
Thank you.
I want to say thank you to all of the speakers for providing your time and knowledge and expertise. I just have a few wrap up points and takeaway points. But before we get started on those points, I just want to share a personal story. I often tell this story about how my grandfather, he had dementia in the last 5 years of his life. And my grandmother was able to keep him at home for a long time because she used adult day programming and services that were housed at a church. And so she was able to get a grant and able to get him to attend that program for free because she wasn't able to afford it because a church was there and they were providing those services. So it's so important to think about how, as you all have mentioned, the importance of church and how they can be a place of respite for caregivers and also provide wellness for community, and think about how to leverage that time, space, and also the volunteers who are there. I really think it's important how we highlighted the importance of and the role of education, how we should be educating faith leaders and congregations, and particularly those who are in spiritual training on what is it like to have dementia and the integral role and support that they can provide for those living with dementia and their care partners. And thinking about how education is important is also important to think about. We've stressed the importance of relationships and how trusted relationships that churches already have with their congregations, for example, can be a great segue into public health agencies providing critical information and critical resources to those who might be living with dementia and also for their care partners. And in thinking about these relationships, it's important to show up and to really provide care that is focused for what the community needs, and doing this with love and compassion, and not just showing up for a one-time thing, but making this a sustainable relationship that is developed over time. And then lastly, it's so important, support. Those who are living with dementia and their care partners need oftentimes a lot of support outside of what they might be getting at the home, but the church or other faith communities might be a natural extension to providing support for those who are living with dementia, and also people who are caring for those in their family who is caring for those individuals. So really thinking about how fellowships and facilities can be adapted to be more accessible for dementia. We really need to provide really more insight on those things. And then lastly, I think it's important, and what's been highlighted from this webinar today is how local communities, churches, faith communities, and also public health agencies, how potentially they can partner with researchers and scientists who are already developing evidence-based programs to inform care and care supports. So I just want to say thank you again for providing this information. I know that the audience has been really enthusiastic about you all's presentation and looking for those slides and such. At this time, I just want to give a quick couple of updates about things that are going to happen in the future. This is part one of a 3-part series that we're going to have. And so it's so exciting that we'll be continuing this conversation in various forms. Our next conversation focusing on faith and public health agencies is going to be on September 14th. And then the next one will be in October. And so please stay tuned. We have a lot of things that are being planned, so we don't want to spill too much out the bag, but just know that it's going to be a great conversation. And then my favorite time is the Q&A, because I think that a lot of times people have questions because there was so much information that we learned today. And so if there's any questions, please feel free to ask your questions so we can get them answered by these experts. So you can use the Q&A feature that is below on the screen, or you can type them in the chat. So I'll give you a few seconds to put some questions in the chat. I know that one question that I've seen quite a bit is, are we going to be able to have access to these slides? Yes, you will have access to the slides. All of this information will be sent to you. And then also this information is always stored in our resource library on our website. And we can put a link to our website in the chat too.
So, Dr. Parker, I'll just want to share this. I put this in the chat box, but for those that are in the area around University of Minnesota, that I will actually be there next week, and we're actually hosting a dementia-friendly workshop for church leaders on next Saturday. So for anyone that is in the area, any of the faith communities that are on, or any public health agencies in the area that think they partner with any faith communities, they may be interested in attending this workshop. It will be 3 hours in length. I would love for them to reach out to me, and I can provide more information, as we're actively looking to partner with African-American churches in that area to bring these additional resources to them.
Great, great. Thank you for that. Thank you for sharing that information. I do see a question from Cynthia Ray. The question is, how do you suggest congregations and faith leaders collaborate, partner with senior living providers to extend ministry to memory care residents and their families? I will open this up to any of the speakers who would like to answer that question.
So I know with some of my faith communities already have established partnerships with senior living providers. But for those that we try to help with, we actually try to find out who's that contact person. And sometimes we have to go through their recreational therapy, like through that department, who does some of their recreation activities, and approach it and work with them to be able to provide resources to come in to provide ministry. During the pandemic, things change, and it looks a little different versus pre-pandemic. Yes, thank you, Mary, for correcting me. Activity director. Yes.
Teamwork.
And so, that's one of the ways that we connect with the activity director to be able to see if we can get on the calendar and have our church offer any of their ministries to them.
And may I add something?
Yes.
I think that, thank you, Dr. Epps. I think in addition to that, one of the things I experienced as when working with people with dementia at the senior residence where I was, is that one has to coordinate extensively with the activities director, not just to make it happen, but to make sure that everything that is needed is there. The residents have to arrive on time. The residents you have to have somebody around during the service or whatever it is that you're doing to make sure that if there's a resident that needs attention, gets the attention, and the group can continue doing the work of participating in the service, etc. There's a lot of logistics involved, and sometimes we who work, priests or rabbis or whatever, we tend to not think about that. It's probably the most important part, make sure that the logistics are right so that the service can go on.
I appreciate that. So there's another question for the clergy. Is there a reference or list somewhere to the most key scary questions faith leaders are asked by people with dementia or their families? The questions you are most uncertain about answering?
I don't think that there is a list per se out there. I think that there are some really good books about spirituality and dementia, but I'm not aware of a list per se. I think the deep questions are, the why me? Where's this going? Will God remember me when I don't remember anything about me? I think there are existential questions about loneliness. But I don't think that there's a written list anywhere that I'm aware of. Rabbi, maybe you are.
Thank you, Reverend Lind. I agree, but I would like to add that the most scary question is a question that is not asked. People with advanced dementia have questions, have thoughts, and they are not able to share them with one who's visiting. And it's very difficult to deal with that. So that's the most scary thing. Questions they ask are the questions we all ask, and maybe they're prompted by their situation to be a little bit more, deeper. But it's the question not asked for me that is the scary one.
Yeah, and I think the other scary question is the question of uncertainty, especially for those of us in the early stages after diagnosis, is what's this road going to look like? And am I going to be alone as I walk this road? Are people going to abandon me and my family along this journey? I think that's for me, that's a huge question that I find myself asking is, how do I live with this uncertainty and this, how long is it going to be, and what are going to be the next plateaus, and what's the future going to feel and look like?
I appreciate you sharing that perspective, Reverend Lynn. Thank you. We have time for about maybe one or two more questions. So the next question is, how can the many chapters of the Alzheimer's Association get information to churches that are hesitant to reach out for resources?
Well, I'll respond to that. I think it's to send it directly and to take the time to communicate directly with the clergy in charge. One-on-ones, setting up appointments, getting out and going and seeing them, getting on their agenda, asking to get on the agenda of the interfaith organizations, asking to get on the agenda of the clergy associations, albeit it's harder right now in this COVID tide. There's no question.
And I agree with Reverend Lynn, is, reaching out to them, getting on their agenda. And one thing I would like to also add is to be persistent.
Right.
A lot of times that, we get no all the time. And I don't think people should see as a no or not right now, or someone not responding as, oh, that's it. They're not going, we can't connect with them. I think we do need to be persistent and to try, because, like we're learning today, there's some things that are pressing, could be pressing for them that week or that day. And we just have to acknowledge that. And, one of my things is I don't give up, I'll try back and follow up. And then eventually I'll be able to get that time to share and to be able to get on their agenda. So things just does not happen overnight for me. It has been months, and I could go on the agenda, Reverend Lynn, and attend their alliance meeting and talk about it, and nothing happens afterwards. I don't write them off. I ask to get back on the agenda.
I think thinking about what are you giving way before you think about what am I getting. That's down the road.
It's like any other kind of a sales pitch. You make the pitch, but you got to follow up. And everybody wants the time and attention of clergy and congregations these days, because people know that that's where you can reach large audiences. And also helping them to see it's in their self-interest and why.
And I think sometimes also when you receive the initial "not right now," it's not personal. However, instead of, I find in being aggressive and calling a lot, sometimes just show up and be present at the service. A lot of times you may have an opportunity to speak with a leader or not, and when you do so, still not aggression, but be there because you're concerned about the needs of the community, not because you need something from them. And I think that happens a lot.
Well, we have a minute left, and so I know that we could talk all day, but thank you so much. I just can't extend the gratitude for coming, for the speakers today, and then also for the audience. As I mentioned, that we will have all of this information in our resource library that will be on our website, and then also we will email out our slides as well. And so please feel free to connect with us, stay in touch. We have 2 more great webinars coming out on this topic, and we have other programs coming up in the future as well. So thank you for coming today, and thank you again to the speakers, and I hope that you all have a great afternoon and a great weekend, and stay well and take care of yourselves.
Thank you.
Thank you so much.